going live in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and blast off. Give me 1 minute. Huh? It's not live. Yeah, now it is. Ashok, you're doing it on Ortho TV? Ashok, you're here? He's not here. I'll do it. Good evening, everyone, and good morning to Dr. Frank, and good afternoon to Dr. John, and I think good afternoon, Dr. Levi. We welcome you all. On behalf of Ortho TV, I am Dr. Neeraj Bijlani, and we are having this webinar today on current trends in shoulder arthroplasty, brought to us in collaboration with Evolutis India Private Limited, and we hand over to Chairperson Dr. Sanjay Desai now to take over the proceedings. Over to Dr. Sanjay Desai.
Thank you very much, Neeraj. At the outset, I must thank all the three faculty. We are very privileged to have with us Mark Frankel from Florida, United States, Offer Levy from Reading in England, and Jean from Belgium. All are very well-known names, and we are very pleased and happy to have them with us. The flow of events is going to be, each speaker is going to speak for 15 minutes. Then we will have question answers at the end of all the three talks, followed by a few cases which I have to show and take opinion of the experts. And if time permits, Offer also has got a couple of cases to show us. So we kick off with the first talk, which is on surface replacement by Offer. Thank you, Offer, and take it.
Thank you very much, Sanjay, for inviting me. Let me just, 1 second, I'll share my screen with you. Okay, so I'm going to talk about the current status and future of surface replacement. My disclosures are here. I have no financial interest with the surface replacement. I just supported my my mentor and friend, Steve Copeland. So development of shoulder replacement actually started with Emile Perrin in 1893, where he did this shoulder replacement infection. Then in the 50s in Stanmore, the Jackson Barrows shoulder replacement, big stemmed implants were spacers for tumors. Later on, the Stanmore shoulder was a mini hip that was modified for shoulders. And on the other side of the Atlantic, Charlie Neer developed the shoulder replacement, mainly to treat full-part fractures, where he needed a stem for scaffold. None of these were developed as for arthritis. And let's see how arthritis affect the bone. It's actually roughen the bone end, and therefore you need a new surface to the bone. And it doesn't matter if there is a stem down the mid length of the arm or just a surface replacement. And definitely there's no need for a stem which is half the length of the humerus. And Steve Copeland, my mentor and friend, was a game changer when he introduced the Copeland resurfacing. We showed very good results, and many others as well over the years, many good results with the surface replacement. As you can see here, 3 examples with young patients that return to full activities, including sporting activities, and good long-term results. It's a very reproducible implant. Here is a study by Mike Thomas from Windsor, and he compared his results to our results as the designing center. and his results are almost identical to ours. So if you do it properly, you get very good and reproducible results. And you can see here when we compared our results, different studies with a surface replacement to a long-term series with stemmed implants, you can see that we are in line and not inferior, sometimes even superior, but in line with the stemmed implant series. So the question is, what are the indications for surface replacement? Arthroplasty is out. The indications for resurfacing are the same as for stemmed arthroplasty for any shoulder arthritis. And actually the question is now, what are the indications for stemmed shoulder prosthesis? And again, it is where you have an acute fracture, we need a stem as a scaffold, or there's no severe bone loss, there's no bone to resurface. But I must say that nowadays, this actually is answered by the reverse shoulder replacement and not with a hemi anymore. Why not to use a stem in shoulder replacement? Because intraoperative humeral shaft fractures on preparation, loosening, stress shielding, as you can see on the left side, disappearance of bone and tuberosities, traumatic periprosthetic humeral shaft fractures due to stress rise at the end of the stem, and difficult revisability. So it took us many years to convince the shoulder world that a stem is not needed. And only in the late 1990s and the mid 2000s, following many publications on the long-term results of the Copeland shoulder, the interest started with resurfacing prosthesis, and there was a change in perception. And many surface replacements appear in the market, and good results were published with a different shoulder resurfacing. Now there is a problem, what to do with a glenoid, because when you do a surface replacement, the head is still there. And indeed, the exposure of the glenoid is somewhat more challenging than if you resect the head and go to the glenoid. However, it is possible, and if you do it properly, you can do it. As you can see in the pictures in front of you, you can push the head posterior inferiorly, and you can actually drive a lorry into this shoulder, let alone a glenoid. Now, what we do a very thorough release around the glenoid. We prepare the glenoid as for total shoulder replacement, and we stop short from putting a glenoid component there. But we stop short not because we couldn't do it, just because we believe it's not good, and I'll show you in a minute. What we do, we call it a total shoulder replacement with microfracture of the glenoid, and not putting a glenoid component. And you can see on the video on the right, the fiber cartilage that you can see later on the glenoid. And here's some examples with a Copeland and with other resurfacing of total shoulder resurfacing. So you can do it, it can be done, but there are problems. And we know that the problems with any shoulder replacement, whether it's resurfacing or stemmed implant or any implant, is the glenoid side. And this is the study we did in 2010. We looked at surface replacement, total shoulder replacement, compared with humeral resurfacing with microfracture. You can see here that the results with the constant scores, a different part of the constant scores, the range of movement, are very, very similar between the humeral resurfacing and the total resurfacing with a metal back glenoid. However, if you look on the survivorship of the humeral resurfacing without insertion of the glenoid is 97.1 in 17.5 years, compared with 81.7 if a plastic was there on the glenoid, and very little different in the outcomes. And this is not specific to a resurfacing. Again, this is what the problem is: wear of the polyethylene, loosening of the all poly glenoid with cement, or severe wear of the metal back glenoid. And you can see here from the paper from Edwards and Walsh in 2003, the survivorship of hemi versus total in stemmed prosthesis. And you can see the same pattern where where you have a total shoulder, you have severe wear, more wear, and less survivorship than the hemis. So we looked at our young group of patients less than 50 years of age, with long-term follow-up, more than 10 years follow-up, 10 to 25 years follow-up, with a mean follow-up of 14.5 years. We had 54 surface replacements, and for the different diagnoses, rheumatoid, osteonecrosis, fracture sequela, etc. We had 14 total shoulder replacements with a metal back glenoid and 16 humeral resurfacing with microfracture of the humerus. As you can see, we follow them with a constant score, subjective shoulder value, and range of movement. Here you can see a young lady, 19 years after resurfacing, what I put hemi with an asterisk, so it's a humeral resurfacing with microfracture. You can see this is her function and her x-rays 19 years down the line. You can see the improvement in the constant scores in the two graphs for the different diagnoses from pre-op to post-op, and the final subjective shoulder value was 8.7 out of 10 in general. When we compared the group of the total shoulder resurfacing with a metal back glenoid compared with the hemis with the glenoid microfracture, you can see that the results were less favorable with on the long term with a total shoulder replacement, and hence we are doing more and more resurfacing of the humerus with microfracture of the glenoid. Some radiologic findings: we had 92% of the humeral implant had no lucencies around the implant. There were a few lucencies around, but these were in the total shoulder arthroplasty, so probably a wear disease because of the polyethylene. The glenoids, on the other hand, we had 44% of loose glenoids, and as you can see, we had 58% of the shoulders show some degree of superior migration over time, and this is represents the deterioration of the rotator cuff function with time, and this actually we've seen and other people described with stemmed implant, with stemless implants, etc. So it's actually deterioration of the rotator cuff, nothing to do with an implant that is there. We had 32% of glenoid erosion at some point, and the majority of them actually stabilized at a certain point and didn't progress any further. The results, the outcome was still good. Some of them actually, or most of them, were correlated with rotator cuff failure, with superior migration as well, and it was more prevalent in the rheumatoid arthritis group. So here you can see we had to revise 3 of these cases were revised to a stemless reverse shoulder replacement due to cuff failure at 12 years, 16 years, and 23 years after the surface replacement. This young lady was the youngest patient that Steve Copeland did. She, at the age of 22, because of juvenile rheumatoid arthritis, he did a total shoulder resurfacing with a metal back glenoid, as you can see. This is 23 years later. She's 45 years old, still very young, and she lost the rotator cuff, as you can see. So I revised her to a verso, a stemless reverse shoulder. This is now 6 years down the line after the revision. She's still very young, 51 years old. She's excellent function, excellent range of movement. Well, I don't know if this will last for the rest of her life, but still she's got all the bone stock there. And if something needs to be done further, it can be done. So we can see here that the survivorship of the surface replacement in the surface replacement of the humerus as well alone was 85%, whether the total shoulder replacement were 61% in 23 years. Sorry. And patients are returning to sports, any sports. There are almost no limitations to any sport as long as the patient knows the risks, because there's no stress riser in the mid shaft of the humerus. They can do any sports they want, almost as with normal shoulders. Again, another patient here with a valve B2 glenoid again that returned to his windsurfing without any problems. Radiographically, on the long term, we've seen good incorporation of the resurfacing. Sometimes we have to use bone graft and bone graft substitute if we don't have enough bone to resurface or to cover any deficiencies. And we were lucky enough to have some patients that donated their bodies, and we could do these laser cuts, and you can see good incorporation of the bone under the prosthesis. You can see in the hand that I'm holding in my hand, we follow our patients to the grave, and we manage to find what the shoulder is doing later on. So it took about 20 years to persuade the world that a stem is not needed. However, the glenoid access is more difficult, more demanding with the humeral head in situ, and some surgeons were looking for ways to make the glenoid exposure easier. And if you resect the head, you have easier exposure to glenoid. And then the stemless anatomic shoulder replacement in Europe came into place about 2005, the TESS shoulder and the Eclipse shoulder. And they showed good results comparable with third and fourth generation standard stem arthroplasty. The idea was that they combined the advantage of no stem and easier access to the glenoid. Looking at the studies, the large studies with the TESS, with the Eclipse, you can see here that they've done at least as many hemis as totals, or sometimes even more hemis than totals. Let's see what's the advantage of the stemless implants, or anatomic reconstruction of the center of rotation independent of the shaft axis. It enables reconstruction or in malunited proximal deformity, easier access to the glenoid because the humeral head is resected. There's a reduced risk for intraoperative humeral shaft fractures, reduced blood loss, reduced operative time, reduce the risk of stress shielding of the proximal humerus, reduce the risk of periprosthetic humeral shaft fractures. It's bone preserving and easier revision. But if we compare it to the resurfacing, the only advantage of that on the resurfacing is easier access to the glenoid because of the resection of the head. And there's a disadvantage as it's been less bone preserving than the resurfacing. So I just want to be a bit provocative and ask you, if you look at the stemless anatomic series, the TESS and the Eclipse, the majority of cases, they perform as hemiarthroplasty rather than the total shoulder replacement. As there's no need to insert a glenoid, which is the only advantage of the stemless on the resurfacing, why to resect a good bone, a good head, humeral head, and not to just resurface? Don't answer, just think about it. So what's the future? Well, resurfacing is getting some bad press in recent years, and for the very wrong reasons, because I still believe and I know that it's an excellent implant which gives you, actually give you all the options for the future. The resurfacing is blamed for being overstuffing, mainly by Perman Sat in his presentations. But I must say that you can do a good job or a bad job, whether you put a resurfacing implant or you put a stemmed implant. And as Charles Neer taught us, that the shoulder arthroplasty, whether it's anatomic or reverse or any, it's a soft tissue operation, and you have to have a good soft tissue balance. So you can have an overstuffed joint, whether with a surfacing or with a stemmed implant. And it doesn't matter which is the spacer, because the shoulder replacement is just a smooth spacer that you have to have a good balance of the soft tissue to make it work well. So I'm happy to see that in recent years, actually, the idea of resurfacing is not completely dying, as some prosthesis like this catalyst prosthesis in the States is coming up, which is something in between resurfacing and a stemless implant. Again, but the whole idea of stemless, the whole idea of resurfacing is still there. We know that, as we can see here from the graph from the Australian NGR or any NGR that you'll pick up, that the proportion of reverse shoulders are really growing high in expense of any anatomic shoulder replacement, whether it's resurfacing or a stemmed implant. And the indications for reverse are actually expanding because of the good results. However, bone preservation continues to be crucial. And in that in mind, actually, we designed many years ago and been using it for more than 14 years now, with more than 14 years good experience, the Verso, which is a stemless metaphyseal reverse shoulder replacement. We see a very good long-term results and an excellent function without deterioration or subsidence or loosening of the prosthesis over more than 14 years now, as you can see here. So what I would say the indications nowadays. So what are the indications nowadays? So if I have an concentric osteoarthritis, like you can see on your left, with a young patient with a good rotator cuff, I will do a shoulder resurfacing. If I have a cuff tear arthropathy, osteoarthritis with Valge B2, that can be debatable whether we can do resurfacing or reverse, but I'm leaning more towards reverse now because the results are more predictable. If there's any doubt about the deficiency of the cuff or questionable rotator cuff, fracture sequela, rheumatoid arthritis, I will do a stemless metaphyseal reverse shoulder replacement, as you can see on the right. Thank you very much.
Thank you, Ofer. That was an excellent, very eye-opening presentation. And like we discussed earlier, we'll have the questions after all the three presentations are over. So may I now invite Jean from Belgium to tell us about his vast experience of stemless shoulder replacement. Over to you, Jean. Ofer, you need to stop sharing your screen, yeah.
Yeah, I stopped sharing. I'm not sharing it.
Hello, everybody. Thank you for inviting me. I'm very glad to be here today with you. I will speak about stemless shoulder arthroplasty. And these are my disclosure. The goals of shoulder arthroplasty is the pain relief, restoring motion, strength, function, and to improve activity level. How to achieve all these goals? We must reconstruct the anatomy of the proximal shoulder. And for reconstruction, in the past, we need the shaft, the axle of the shaft. But the two factors, the most important, there are the right head size in the right position. And when we have deformities, it's very complicated to use your axle of the shaft. That's why we are today to speak about stemless prosthesis. What's a stemless implant? It's an implant with a metaphyseal-based impact or screwed, with no intramedullary stem, without cement, with a head fixed by a Morse taper. There are a lot of type of prosthesis. The history of the modern stemless prosthesis starts in 2004 with the TESS prosthesis. After that, we had the Eclipse prosthesis from Artex. Sidus prosthesis, it was in 2012. In 2008, we had the Matisse short affinis prosthesis. Unique simplicity in 2010, unique in 2015. We have the possibility to convert with the Lima prosthesis. We have the possibility to convert with the FX solution. And we have also a reverse verso prosthesis with stemless configuration. Will stemless prosthesis dominate the market? This article in 2008 anticipate that in 2025 we'll have more anatomical stemless prosthesis than stem prosthesis, according to the eData research, and we'll have an increased number of reverse total shoulder arthroplasty with stemless prosthesis. It's better to be short. It's now a trend today to shorten the stem, from long to short, from short to stemless. Let's see if the outcomes, what are the results of the midterm, short-term, and long-term outcome? What are the results in the mid follow-up and the long follow-up? We start with a team from France and Belgium who reported in 2010 63 patients with a good constant score, and we arrived at the multicentric study of Sean Churchill in 2016 with 149 patients, and we observed that we have good constant scoring and midterm and a rate of revision between 0 and 11%. We have also 2 follow-up outcomes coming from the studies of Howie with a group of Peter Habermeyer. 49 patients, 9 years follow-up. They observed no loosening of the humeral implant, a revision rate of 6.9, and due to the cuff tear, secondary cuff tear, they revised one prosthesis. They made one pectoral major transfer. They observed also a periprosthetic fracture healed conservatively. And the conclusion was that the humeral implant related complication was 0. What are the results in the reverse total shoulder arthroplasty stemless? We see that the complications are the same, like in the stem prosthesis, with metaphyseal fracture, with instability, with superficial infection, acromion stress fracture, but also we can observe in the midterm studies that the undisplaced fracture healed around the implant, that the late periprosthetic fracture healed conservatively without plate or wires and with a very good function. More than 40 years now, long-term follow-up of Levy show excellent clinical and radiologic results with the bone preserving, and this anticipate also that the stemless reverse total shoulder arthroplasty will increase in time. We have some studies who compare stem and stemless, and we observe also that the results are the same in the stem group and the stemless group. Also, we can observe that we have more radiolucent lines in the stem prosthesis. And back in 2018, told us that the stemless total shoulder arthroplasty had stood the test of time concerning the score, radiographic loosening, complication rate, and implant survivorship. We can compare also the revision of the stem failed prosthesis and the stem prosthesis. And we can see that better results are in the stemless prosthesis with shorter surgical time, better constant score, more complication in the stem group, and we also observed that the fenestration for the humeral, it was necessary only in the stem implant. Should we use a stemless implant today? Yes, as Levis already told us, we preserve bone. We reducing the operating time. We can be independent from the shaft. We prevent fractures. We have less invasive exposure with less blood loss. Easy to revise, but also unrestricted to the glenoid approach. With 10 years experience in Europe, I think we can use now the stemless implant. How about the limitations? We have some limitations when we have poor bone quality, when we have osteoporosis, when we have metabolic bone disease. The metaphyseal cysts, they are not anymore a problem. We can allow also to put a stemless implant if we use a bone grafting from autologous head graft. Is stemless best implant? Is the best choice today? I don't know if it's the best choice. I know that for me, it's a good choice when I have a canal deformity. I know that we have good results in short and mid-term and promising long-term results. I know that we have no complication related to the stem, and it is easy to revise. And if we revise, we will have better function. These are some of my cases. I use it for primary osteoarthritis. I use it for secondary osteoarthritis. I use it for anatomical isolated neck fracture without metaphyseal fracture. I use it also for sequela of anterior instability. I use it also for posterior dislocation locked even if the patient has epilepsy. I use it in avascular necrosis. I use it in post-trauma cases with corticoid necrosis, post-induced. I use it like hemi-arthroplasty, or I use it like a total shoulder arthroplasty. And yes, like in the literature, I already revised the cases, but not for humeral lost bone, I revised it for glenoid wearing for a patient with a infraspinatus, supraspinatus fatty infiltration. I don't have experience with the stemless reverse shoulder arthroplasty, and I used a short stem adapted in valgus to create better seating of the prosthesis. I also use it in the trauma cases, complicated cases who arrive in my hospital, operated in other hospitals, like this case with such an ugly fixation, with a head who collapsed and with a big deformity of the proximal humerus. I put it a total stemless prosthesis. And 6 months after a fall, the patient arrived in my office with some pain and loss of range of motion. And you can see here, it's a problem of the glenoid. By the humeral part, it's very good. We have also a subscapularis rupture. I revised it with the same prosthesis, short stem, cemented this time. What can we do with stemless prosthesis? We can use it with a good and excellent results in post-traumatic cases. We know now that we don't have stress shielding. We don't have humeral loosening, and it is easy to revise, because in my hand, it's better to revise than to convert. It's not such an easy operation. It's sold like a very easy operation, but we don't have the guide, the intramedullary guide. We can have a problem with the cutting varus. We try to do minimally invasive exposure. We can have problems with overstuff, like Levy said to us, and a big importance to the subscapularis fixation, because now with this type of prosthesis, we don't have anymore the possibility to augment subscapularis repair around the humeral stem. Thank you very much.
Thank you, Jean. That was very informative. And I'm sure you'll have a lot of questions. We now invite Dr. Mark Frankel to make his presentation on reverse shoulder arthroplasty. Mark.
I'm going to talk a little bit about reverse shoulder replacement, specifically about lateralization and reverse shoulder replacement. And here are my disclosures. So the ideal reverse prosthesis should fulfill two criteria. One, it should provide the greatest impingement-free range of motion of the glenohumeral joint. And ideally, it should restore optimal muscle length tension relationships to optimize muscular force and power about the shoulder. So which designs provide the greatest impingement-free range of motion? Well, here's a study that was performed by the St. Louis group by Jay Keener, and they used a virtual implantation, and they found that the ideal range of motion is achieved with a 10 millimeter lateralization on the glenoid side and 5 millimeters of retroversion of humerus with a varus 135 inclination angle of the humeral implant. This is another study that was performed by Joe Walsh's group, doing a similar type of analysis. And again, they looked at what would be the ideal neck shaft angle and glenoid lateralization to optimize impingement-free range of motion. And they also found that a lower neck shaft angle and a lateral glenoid was best to provide impingement range of motion. This was a study that we performed 12 years ago, where we looked at 483 different combinations of implants and also surgical techniques. And we found that in fact, the same results, that a lateralized glenosphere and a neck shaft angle of 135 degrees provided the greatest impingement range of motion, as you can see sort of in this fluoroscopic view of this patient that was 15 years ago. So the next thing to consider is what designs will allow optimal length tension relationships to the muscle tendon units about the shoulder. So we were often told initially that we had to have a non-anatomical reconstruction which distorted this, but in fact it is possible to try to minimize the distortion of the normal anatomy. So if you were to look at the normal shoulder and assume that the length tension relationships of the muscles are ideally positioned in terms of their length and tension, you can look at different implants and how they might change that. So for example, with the traditional Grammont, you distalize and medialize. With a lateralized Grammont style, you still distalize and you lateralize a bit more. If you use a lateralized glenosphere and an inset humerus, you come closer. And then if you do a bio-RSA, you still distalize a bit more. So you can look at these different designs and already intuitively start to imagine what would ideally provide you the best length tension relationships of the muscles around the shoulder, subscap, infra. And if you have an intact cuff, as Ofra said, we're using reverses for patients with intact cuffs frequently now, that these different parameters will provide the ideal function of the muscle tendon units about the shoulder. And if you were just to look at these two designs, you can see how the length of the deltoid and the contour of the deltoid is affected. You can see if you lateralize and you minimize distalization, you get a good wrapping of the deltoid as opposed to over lengthening of the deltoid as seen on the lateralized humerus. So the optimization of muscle function is dependent upon the length and also the cross-sectional area. So when you distalize and you make the muscle longer, you actually decrease cross-sectional area and you actually diminish the function of the shoulder. So if you inset or onset your humeral component, you also will change the optimal functioning length of the muscle, because the geometric center, as we talked about with the anatomic humerus, have a great deal to do with how the muscles around the shoulder wrap around the glenohumeral joint. So when you have the inset component where the center of rotation and the pivot point are closely aligned, as opposed to an onset where they're offset, you have a different wrapping of the cuff muscles. And you can see what happens when you have an onset, you tend to distalize more and you offset the rotation of the socket relative to the axis of the humerus. And that often leads to people unable to repair the subscap. And then that often will lead to over lengthening of the muscle tendons, which probably leads to fatigue at some point. And we know that if you over lengthen the deltoid, it has consequences in that people have loss of function over time. And this is likely something that might have implications of the long-term outcome of reverse shoulder replacement. And again, one of the basic principles is you'd like to have the shoulder on the left as opposed to the right. So when you restore the contour of the shoulder, you're actually doing something more than just cosmesis. You're actually anatomically idealizing the muscle tension relationships about the shoulder. So in conclusion, the ideal reverse should have the greatest impingement free range of motion, optimal muscle tension relationships. That would include a lateralized glenosphere, a varus neck shaft angle, and a humeral component. So what are the outcomes of this? Well, this is a 10-year study of a lateralized glenosphere. It had a center screw base plate. This is the different features of that implant. And we first reported on the 2-year outcome. This was the only independent device, exemption device ever in the United States on reverse shoulder replacements. And this was the patients in this study. And you can see this is how we collected the data. So now we have 10-year data and a minimum of 10-year follow-up. Again, this was published 3 years ago. We can see that these are the outcomes. And what we find is not only are the patients still doing well with a very low revision rate of about 5%, but they have minimum of function. Their function is not decreased. So they have high success in terms of durability, but they also have preservation of their functional outcomes. How does this compare to the other 10-year studies? Well, if you look at these studies that have similar follow-up times, you'll see that these patients had much more notching, and they had a greater likelihood of humeral loosening. They had the same survivorship at 10 years, but they noticed this decrease of function about 7 or 8 years. And they said they didn't know what the functional problems, why they started to lose function. Here's another study similarly, that they had a similar follow-up time. Again, at 6 years, they started noticing this decrease of function. They didn't talk about notching. And here finally is a large series, similar 10-year follow-up, 90% survivorship, but again, this decrease at 8 years. So it's really important to understand that when you look at the outcome of reverse shoulder replacement, even though the survivorship at 10 years is the same, the outcomes actually change, and the radiographic changes are significant, with the medialized centers having a high rate of notching. And it's likely that there must be some impact of the polyethylene wear. So again, a lateralized implant had low notching. It had patients that maintained their mechanical ability to function, and they did not have an increased risk of mechanical failure. Whereas the medialized type of implants, even with lateralized humerus, they began to deteriorate at 6 to 8 years. So really we need greater than 10-year follow-up to see how patients do. So in summary, this implant tends to have survived the time, and I appreciate your time and attention. Thank you.
Excellent, Mark. That was wonderful. That has really updated us with your experience of having lateralized on the glenoid side. Now we will take questions. So the first question is from for Offer. Offer, you can unmute your mic, please. The question is,
Can you hear me?
yeah, Offer, can you hear me?
Yes.
Yeah, question for you is there overstuffing? Is overstuffing a problem with the Copeland resurfacing? I know you answered that, but the question, so maybe you can perhaps briefly tell us again.
Well, it's a good question because that's a major point that is missed. People think that resurfacing is an easy operation. It's not an easy operation. It's an operation like any other shoulder replacement. And you have to pay attention to the soft tissues. The soft tissues are the key, whatever shoulder replacement you do, for good function. So a lot of surgeons are thinking, oh, that's an easy, we just open up, we put this resurfacing on top, and we go home and that's fine. And that's why you get the bad press, the bad reputation of a stuffing or function which is not as good, or wear of the glenoid. As I mentioned in my talk, we do a total shoulder replacement in every resurfacing. So we do a very thorough soft tissue release. We address the glenoid. We don't forget the glenoid. We address the glenoid as if we are going to put a glenoid prosthesis inside. We just stop short of putting the plastic in because of the results I showed you, that on the long term, unfortunately, whatever prosthesis we use, we still don't have a good glenoid that will last for a long time. In all the implants in the world, the glenoid is the Achilles heel of the prosthesis. And we found out that our results without the glenoid implant are at least as good as the one that we put a glenoid in, but on the long term, they are by far better. That's why we don't do it. So again, I think that overstuffing, you can overstuff with every prosthesis we use. You have to pay attention not to take enough bone from the humeral head to put it in the right size. I agree that in the Copeland shoulder, one of the, again, the Achilles heels is the jig to measure the size, because that needs an experience and this thing that can be improved. But other than that, if you do the right size and if you do a good soft tissue release and you address the glenoid, overstuffing is not a problem.
Thank you, Ofer. The next question is for Mark. Mark, would you mind to unmute yourself?
Sure.
Yeah. Now, we were told that the basic principle on which the reverse shoulder arthroplasty works in cuff deficient shoulders is that there are 7 functional components of the deltoid, and they are at a mechanical advantage in providing forward elevation simply because you medialize the center of rotation.
Yeah.
So when you are lateralizing, you are defeating the basic fundamental of a reverse shoulder arthroplasty in cuff deficient
Okay.
shoulders. How do you
Hold on.
justify?
Okay, so I have to get off my horse here. And if I could beat you with a stick after saying that, I would, because I believe that is something that has been said, but there's no justification for truth. So people have said that's how it works, but it actually doesn't work that way. And there's a lot of evidence to support that. So the first portion of evidence is if you were to ideally design a muscle tendon unit to function as it does in our body, you would see the biggest requirement to providing power for that muscle is actually having a normal length tension relationship of the muscle. And if you change the length tension relationship of the muscle, regardless of the moment arm, it really doesn't provide the same impact. So when you change the length tension relationship, like with a gourmet, where you medialize the center, you compensatorily lengthen the deltoid. And by lengthening the deltoid, you actually make the deltoid thinner. So the cross-sectional area now is reduced. And you also change where the sarcomeres actually have their best function. So when you look at how muscles function, it's that interchange of the sarcomeres with the actin and myosin filaments that provide power. So when you over lengthen the deltoid, and you imagine now by doing so, you're going to make up for that deleterious effect on the muscle by improving moment arm, it's a fallacious belief. We know that the more we can reconstruct anatomy normally, the better chance we have a better, durable, and improved function. And it's the same thing as Ofer said. This is a soft tissue operation, and when we use implants, we want to think about what implants are doing to the soft tissue envelope. And ideally, we want to maintain the line of pull of our muscles. We want to maintain the line of action of those muscles so they're pulling in the same direction. And we also like to idealize the length tension relationships. And if we can do that, we're very likely to see a substantial improvement in patients' function that will be sustained for a long period of time. And again, I think the long-term evidence supports that belief quite convincingly.
Thank you, Mark. I think that is fairly convincing. Neeraj or Ashok, are you there?
Can I add something to what Mark said? Just to
Yes, Ofer.
support it?
Please do.
So, I mean, if we look at the history, I mean, reverse shoulders are not something new. That were here in the 70s, like the Kessel, Lippy Kessel prostheses, that worked very well. And they were very lateralized and they worked very well. The only problem with them was the fixation to the glenoid that now has been changed and is much better. So to say that lateralization doesn't work is wrong.
Got it, yeah. So any more questions?
Yes, sir. There is a question from Pune. How to deal between two sizes if there is a mismatch in resurfacing?
Ofer, that's for you.
Yeah. I mean, again, it's to do with the judgment of the soft tissues. And to be honest, there are 8 different sizes of resurfacing of the Copeland, which will cover most of the spectrum of sizes. I will not overstuff the joint, but I will try to get the good soft tissue tension and the good soft tissue balance when I do it, when I do the prosthesis. And you can put a trial in, you can assess the mobility of the joint. Actually, as you do with a stemmed implant, that you want to have about 50% translation or easy translation of the joint inside, and then you select the right size for that. You can still, with a Copeland, there is a way to, if you thought that you are too large, to go a bit smaller as well. So, I mean, that's a technical issue, but you can cover all the sizes with the available 8 sizes.
Right. There is another question from Dr. R. Pandey from UK. Is overstuffing a problem with Copeland resurfacing, the metal edge rubbing against the cuff?
No, if you do it properly, you don't really disturb the cuff. So I mean, the deterioration of the rotator cuff is something that it's unrelated to the implant you use. We've seen it in all the implants. We've seen it in different studies that on the long term you see superior migration of the humeral head. We've seen it. I mean, Habermeyer with a stemless implant even showed it in his series that there is deterioration of the cuff and superior migration. So that's unrelated whether you use a resurfacing, a stemless, or a stem prosthesis. It's a natural, I would say, deterioration of the cuff or aging of the cuff in a shoulder replaced shoulder.
Right.
I have a question for Jean. Jean, can you unmute yourself? Yeah. Do you anticipate that a large percentage of total shoulder replacements in the future will be stemless rather than stemmed? And do you think the stemmed ones might phase out over time?
It was an analysis of e-data research. They are not orthopedic surgeons, the guys who published the article in 2018. But I think they are right. We have an increasing of the stemless prosthesis because we have now 8.2 increasing rate per year younger patients who need or I don't know if it's a trend, if it's a fashion to have a shoulder arthroplasty, but we can say that we have enough. We have a lot of patients, and the patients younger and younger, and I think in the future we'll must preserve bone. I agree that resurfacing is more preserving bone operation, but I think first of all we must think of operation of today. No, we must achieve the glenoid, but thinking also in the future, because like a young surgeon, I think that sometimes in future we must revise our cases, and if we put more prosthesis, we will have more prosthesis to revise, and if we put more reverse shoulder arthroplasty, we will have a lot of revising of the shoulder, because we know that the complications in the reverse shoulder arthroplasty are bigger. The rate they are bigger than in the anatomic. And yes, I think that in the future we'll have more, and the number of prosthesis and the revision will increase.
Mark, thank you, Jean. Mark, what do you think is the future of stemless in the United States of North America?
Well, I think that there's certainly the advantages that both Mark and Jean have discussed in their presentations. I think the fixation of the stem, you can use a thin stem and not really try to use it for anything other than to help orientation. I think both Ofra and Jean both talked about some of the technical difficulties, ensuring that you restore the head in its proper relationship relative to the axis of the shaft, meaning not in varus. So the stem helps visually help us maintain that proper alignment to keep us out of varus. So you can use, like Rick Matson will use a very thin stem. He'll use impaction bone grafting, and essentially that allows them some freedom to reconstruct the perfect circle of the proximal humerus. But they're becoming more popular. We also have been using a short stem implant on the humerus and on a reverse, much like OFRAS. And I would say that I do have some concerns. I've been using it, but I think it's a little harder for me to adequately understand ideal fixation. So, you know, people talked about how do you determine that you have enough bone support? And you can use some quantitative measures, which we've tried to determine that don't really work very good. And then you have the subjective interoperative decision about whether you're assessing stability. And it's probably because of my learning curve that I don't quite have that down yet. But I think that's one of the challenges, that when you change these things, there is going to be a learning curve. And if you see your complications in your own practice, you might then question what is the actual benefit overall from these shorter stem devices, particularly if you're having a low complication on the humeral side.
So one of the questions from the audience is that if you have, say, somewhere between 50 and 60 age group osteoarthritic with a concentric glenoid wear, and you decide to do a hemi, then should I do a stemless or a surface? So I guess Offer and Jean can collectively, starting with Offer, you have confused the audience. They don't know whether to do a surface or a stemless hemi.
I would do a surface replacement. It's more bone preserving, and I don't see any advantage of the anatomic stemless on resurfacing. I just see that you resect more bone, because if you do it properly, if you put it in the right position, which is the same, difficulty is the same whether you do a stemless or resurfacing, is to judge the right position and the right size. Again, it's not a problem, but it's as you need to learn how to do it. It's not trivial, and as it's not trivial to do a stemmed shoulder replacement. So you need to learn how to do it. If you do it properly, then I don't see any point of doing it. But again, if you don't want to do a resurfacing, then I would suggest to do a stemless and not to go with a stem down the shaft. Because if you put a stem down the shaft, you decided the route of this patient to the end of the days. He will have a stem and will go down the hill. Yeah.
Right. There's a question. Thank you, Offer. There's a question from the audience to Mark that in your cases that you showed, they have noticed that the glenosphere is flush to the inferior edge of the glenoid and is not overhanging as it is recommended to prevent notching.
Yeah, okay, so I like to put the glenoid right in the center of the glenoid as opposed to inferiorly. And the reason is I don't want to distalize the humerus. So the recommendation to place the base plate or the glenosphere inferiorly, they were based upon a design that has a hemisphere. So the glenosphere is half of a circle. And in order to avoid notching, that's what you need to do. If you have a lateralized glenosphere, as the first three studies I quoted show, you avoid notching because by having the center of the sphere away from the glenoid, you push the humerus further away from the glenoid, so you avoid contact. And the two factors that do that are, one, actually the most impactful one is the 135 neck shaft angle. So if you were to say, well, what's the most predictable way to avoid a contact between the inferior port of the humeral socket and the glenoid neck, which is what we would say is an abduction deficit, which leads to notching, you would say the most predictable way to avoid it is actually a 135 neck shaft angle implant by far. The next one would be a lateralized glenosphere, and the third one would be inferior placement. So if you did a hierarchy of what factors would reduce that likelihood, it's those three. And every study that's done that have shown that. And then again, in our study in 2008, where we looked at 483 combinations, it was very clear. And every study since then that have replicated in some way that concept have come up with the same result.
Okay, so there is a part B to that question, Mark, which of course you did show, but since they have asked, I will pass it on to you. Was there an increased glenosphere loosening rate in your series?
No, you know, when I first released the first version of that implant, it was not FDA approved. And I did that series as a single surgeon. And in that design, the peripheral screw holes had 3.5 non-locking screws. And I had no idea about proper placement of the base plate because I was just starting out. So I had a learning curve. And in that series, I had a 10% failure of the base plate. And we did several studies then to identify, well, why did that happen? And the things we identified were, one, the peripheral screws. If you increase the size from a 3.5 non-locking screw to a 5.0 locking screw, that substantially improved the stability of the base plate fixation. And the other one was if you made sure that you did not superiorly tilt the base plate relative to the surface. And when we made those changes, the next series showed a 0.05% failure rate. So those really clearly identified it. And I would just say that if you looked at the bio-RSA and other designs now that are coming out, it's very clear that base plate failure is a very uncommon method of failure, almost independent of whatever you do. So the idea that lateralization would lead to failure on the glenoid side, it just doesn't come out to be true.
Okay, thank you so much. There are many more questions. I'm being told that there are 800 people watching and there are too many questions, but now we will move on to the last section of this meeting, which is case presentations. I will share my screen and the way it goes is I'll show you 3 or 4 cases and ask questions to the panelists for your expert opinion. Mark, can you stop sharing your screen?
Yeah, I did. I'm not sharing it.
Is my screen visible now, Neeraj?
Yes.
Yes.
Yes, sir.
Okay, so here is the first case, a 27-year-old male. This is the only X-ray I have that he had with him. It seems he had a 3 or 4 part fracture of the proximal humerus. Somebody did interlocking nail, and that nail failed. There was avascular necrosis. He went to the same surgeon again who did a CTA head, a cuff deficient head prosthesis. And this patient, who is 27 years old, comes to me for the first time 10 months after their second operation with severe pain and stiffness. So this is the X-ray. I did a CT scan. So we take it from here. So let us ask to begin with offer. 27-year-old male, operated twice, cuff deficient, severe pain and stiffness. Your take.
Yeah, I mean, again, there's the only thing that will work here will be a reverse shoulder. We have a slight problem with some bone loss in the glenoid, as we can see here, which is a bit more challenging. I would, again, try, I don't know if this is a cemented or cementless implant, the Hemi, but I will try my best to remove it and preserve the proximal metaphyseal bone and do bone impaction and try to put a stemless reverse shoulder with a Verso. If I can, if not, I'll use the stemmed Verso. For the glenoid side, again, there is a bone loss there, but the implant that I'm using has got a central tapered screw. And I believe that if you use the screwed base plate like mine or Mark, that's much easier to fix on this kind of bone loss. and I think, I mean, again, it's more challenging than if you have a good glenoid, but then you can adjust it, because the fixation in the prosthesis I use is mainly by the tapered central screw. There's no concern about the fixation even in a bone loss in the glenoid.
Would you do a primary autograft on the glenoid?
I will probably use, again, I'll have to use a bone graft substitute or a bone graft to build it a bit, but I will fix it to the best place that I can fix it, to the best bone, what Mark called an alternative angle or axis. And then I will probably put some bone graft behind. And because of the compression, compressive stresses, later on, this bone will incorporate and will grow behind the base plate. We've seen it in some cases that we've done.
Okay, Jean, I would like you to tell us mainly how will you tackle the glenoid. First of all, you agree that reverse is the only option now?
Yeah, the reversion is the only option. I think this type of prosthesis, it's a convertible one. We can take out the head, and I think the humeral prosthesis is not cemented. We must be sure that it's fixed and is not moving. After that, I will, if it's moving, we will take it out. If it's not moving, we use it to put the reverse prosthesis. And I will use a long peg with the iliac crest, like Tom Norris technique, and 4 screws fixation for this case. I know it's a little bit complicated because it's got only 27 years old, but I think for good function is the only solution. And if you let it like this, I think in several years, you don't have any more enough bone in the glenoid to do better.
Okay, from the CT scan, the axial cut, it looks like the prosthesis was too much retroverted and there was bone erosion posteriorly. So yes, it is a platform stem, but probably we'll have to remove to orientate it accurately. Mark, your take, some from your vast experience, how to deal with this?
So if you look at that one 3D reconstruction you have on the screen there, you can see there where the scapular spine and the body meet. You can see very dense bone right in front of our face. That bone is extraordinarily dense. The scapula is actually a flat bone, so you can't really use the idea of cortical and cancellous bone, but that bone acts much like cortical bone. So if you get into that bone with your drill, you'll feel your drill working. And if you put a screw right there, it's going to get a great bite. So once you have your central device securely attached to good bone, then you can ream the surface around that. If you put a tap in, you can ream that, and then you can get some idea of where the surface defect will be in which the base plate won't be supported by bone. And I would use bone graft, and you probably can take bone graft from the proximal humerus or from the inferior edge of the glenoid to make up for where that bone loss will be. And then in terms of the glenosphere, you have many different choices of glenospheres depending upon the system you use. In the system that I use, we have glenospheres that have different types of hoods that actually extend the coverage that actually then allow you to load share. So if I'm using a base plate and I have, let's say, 30% of my base plate covered with host and 70% covered with autologous or some other graft material, I can select a glenosphere that will actually allow me to have the portion of the glenosphere contact part of the scapula. So when the glenosphere is loaded, it shares the load, as opposed to a glenosphere that is sitting on top of the base plate, which then puts a bit more force at the fixation point. So that would be my plan. plan would be using that alternative spine line where you can see that bone, reaming it, seeing how much bone deficit is there that would not allow me proper coverage of the base plate, grafting it. If it was 70 or 80% of coverage, I would just pick whatever glenosphere that I thought would ideally balance the soft tissues. If it was far less, then I would pick a alternative glenosphere that would allow me to load share across the glenoid surface. And on the humeral side, even if this was convertible, I wouldn't want to convert it because I'd want to inset the socket inside the bone to decrease some of the forces. I do not want this shoulder to be too tight because again, if the shoulder is tight, you increase the force across your fixation.
Right.
Can I say something about this convertible principle?
Yes, John. Yes, Alfred, please.
Convertibility is a good gimmick, but in the majority of cases, it doesn't work. And one of my fellows did a study. They did a study using a computerized system, and they took a very minimal arthritic shoulder, took 6 of these implants that are supposed to be convertible, put the anatomic shoulder in the perfect position, and then just try to convert it to reverse. And you know that the gap between the glenoid and the cut in the reverse is double than in the anatomic. So even in the best case scenario that the first surgeon put it perfect anatomic position for anatomic shoulder, you already overstuff the joint if you convert it to reverse. So, and the majority of cases that you have to revise, it's like these cases where the first surgeon got it wrong. Then in a majority, you have to take it out. So I think that this convertibility, it's not really a convertible thing. We have to talk about revisability rather than convertibility.
Okay, thank you. So this is what I did. I removed the prosthesis. I did a linear osteotomy to remove it. It was well fixed. I corrected the version. I did a iliac crest bone graft to build the glenoid. I told the patient that it will be a 2-stage procedure. I want to first build the glenoid. And now after having built the glenoid, it's almost 16 months and the patient is fairly happy with the way it is. So my second stage of converting this into a reverse has not yet happened because the patient is quite comfortable, though he doesn't have great movement as of now.
Sanjay.
Yeah.
I did this in patients some years ago, and I would encourage you to tell the patient to go in sooner because once the metal head articulates with the metal screw and you get metal debris, things change dramatically.
Yes.
I would really encourage you to think about taking out those screws. Yes, and perhaps do the reverse at the same sitting. Well, was this cuff intact? Because maybe you can just do an anatomic shoulder. I mean, I don't know what I would do, but I would take out the screws. Yeah. No, the cuff is not there. Okay, yeah, I would take out the screws and then convert, but I wouldn't wait. I wouldn't wait because I'd be worried about metallosis developing, and I unfortunately had that. And it usually is about 18 months that they start to have symptoms. And if you wait, then your bone starts to go away quick. Yes, got it. Thank you. So that point is well taken. So
the other point as well, I think that Mark would agree with me that if you do a 1-stage revision and revise and put a reverse, you get a much better result if you go twice on the long term. So I would probably put the reverse straight away on the first time with a bone graft, incorporating it into the reverse shoulder. Yes, I was very nervous about getting a good fixation of the metaglean with that kind of glenoid. So that's the reason decided. And I was also a little concerned, though no obvious sign, but to rule out infection. Hence 2-stage, but there was no infection. So yes, but we will be going in soon, try and tell the patient that we need to remove the screws and perhaps do a reverse 2nd stage. We move on to the next case. Male, 60-year-old, right-handed, had this 4-part fracture, dislocation. Somebody did a open reduction and fixation with a locking plate.
2 months post-op, the plate failed, as you can see here. What next? So let's ask Joe first. Joe, how will you deal with this? This 60-year-old male is a assistant police commissioner. Are you there, Joe?
Yeah, if it was younger, I will try to refix it. But 60 years old,
Yeah.
with this displacement of the tuberosity, I think we can go for a reverse shoulder arthroplasty.
Okay, straight reverse. Okay, Mark, your take.
Yeah, I would agree with Jean. I think if he was younger, you might consider trying to do a re-osteothesis, trying to pull the head out of varus. It's a little concerning because the tuberosities look like they're displaced as well. And I think that probably is the kiss of death. That would suggest that a reverse shoulder would be idealized. And you know, the question is that he's 2 months, and that I guess I probably would not wait, but something about timing. You know, when you do fracture work, if you get them right away, they do good, but there's that time period where they tend to be very stiff, and if you wait longer, I think they tend to be better. So that would be the only thought is, do you do it now or do you have him wait another month or two so soft tissues may calm down?
So Mark, if I can ask you, it's only 2 months since the fracture fixation. He's only 60 years old. Tuberosities don't look too bad in size, and why not do a hemi? Because he's 60.
Oh, I stopped doing hemis some time ago. The problem I had with doing hemis was I couldn't always predict. There's about 80% of the time where they would do very good, but 20% they'd fail. And I couldn't predict which ones they were. With a reverse, you know, I've gotten much, much better with my reverses for 4-part fracture. Part of it is understanding the surgical tactics, and the other one is modifying the implant to be more suitable for reattaching the tuberosities anatomically. So if you do a reverse and you're able to reattach the tuberosities anatomically, and as I showed you in the previous talk, if you get the length-tension relationships right, these patients can have excellent function. So my preference would be a reverse because it's much more predictable. And in my practice, I don't do hemiarthroplasty for fracture fixation. I would dare to say ever, at least in the last 15 years, not once.
Okay, Offer, do you have any disagreement with what Mark said, or you would do a hemi?
I will actually, I agree with Mark. In the last 15 years, I haven't done any hemis anymore for fractures. And I think the only thing that will work here, and I wouldn't hesitate to do, is a reverse. I mean, as Mark said, you can see it's only a shell of the humerus. I don't know whether there is any blood supply to this piece of bone there. The tuberosities are off. If they're still there, too much metal there to see. So I would do a reverse shoulder replacement for this guy. And just to Jean to tell him, he's 60 years old, it's very young.
Right, of course. So this is what was done. A hemi was done and looked very neat, and the GT was well reduced. And in about 5 to 6 months, the GT disappeared. And my question to all three of you is, why did the GT disappear? Can you enlighten us that why such a behavior of the GT?
My main concern from the third X-ray is that there is an infection there.
So we did all the workup. Can I tell you no infection? Now take it from there.
So, you know, one of the things that happens when you look at tuberosity healing in a reverse group of fractures versus hemis, you see that the predictability of healing is far greater. And so one of the reasons is when you do a reverse, no longer does the tuberosities have to contribute to providing stability of the glenohumeral joint. So in a hemiarthroplasty, the deltoid is trying to pull the humerus superiorly, and the rotator cuff muscles are pulling it horizontally toward the glenoid So they're opposing the deltoid. So if your tuberosities are not perfect and they're not robust and healing doesn't occur in a very timely fashion, they'll fail because they can't deal with the unbalance of forces. So when you do a reverse, because you neutralize the deltoid force pulling up, the tuberosities now, they don't have near as much force across them, and they're far more likely to heal. So probably why did the tuberosity disappear? Well, probably a combination of vascular changes, force over time, and the attritional changes that no longer is force being applied to that bony fragment. And because of Wolff's law, it goes away.
Right. Okay. So a reverse was done. Now I show you similar hemis, case 2, 3, 4 done by people, all failed. So we all accept and agree that there is a problem with hemis when you do them for fractures. So I will show you one case now. A male 58, a comminuted 4-part fracture. A hemi was done. That is his function. This was about more than 10 years ago. Near normal function. He likes to play cricket, so he's playing cricket.
Sanjay, it's sort of like the problem with gamblers. It's not losing that causes you not to want to gamble. It's when you win.
Right. Now, the point I'm trying to make is these are these guys' x-rays who had an excellent result. And of course, we can see that the tuberosity is healed beautifully and anatomically. Now, what I want to know from you three is this, that why some hemis do well? Why are we not able to produce result with consistency? Is there anything that we are not doing accurately each time? So let's start with Mark and then the remaining two, Offer and Jean.
Well, in the 1990s and the early part of 2000s, most of my research was in this area, both clinical and biomechanical. And we looked at different designs of implants that would idealize the ability to securely attach tuberosities. We found some suture techniques provided better fixation than others. We found that some fin designs provided better ability to reconstruct the humerus. And then clinically, I did many of these fractures. And what I found is 80% of the time I could do pretty well, but 20% of the time I could not. And there was no way to predict in my hands who the 20% were. So it is by definition in my hands, and I probably did about, I'd say 300 of these hemis. I couldn't predict who it was. And so I abandoned that because a 20% failure rate to me was unacceptable. And when I did my reverses, the failure rate was maybe 5%. And the outcomes actually tended to be just as good. So the idea that a good hemi would outperform a good reverse, I didn't see that. So I think in some situations, the pathology is far more difficult than we appreciate. And our technical ability to resolve that, I think is not quite as good as we would like. So we need to have an implant system that will give us the error of our inability to get it perfect.
Right. Offer, your take. Anything you want to add to what Mark said?
Well, I completely agree with Mark regarding that. The same as in his experience, my experience, you can't predict. Some of them are doing superb and some are doing really badly. And I think part of it is damage to the soft tissues, damage to the cuff that we can't really appreciate during the operation or at the time of the injury, that they are not recovering and they don't really take on and do a good function. And indeed, with my hands as well, with the reverse, I get at least as good results with a reverse as I got with a good hemis at the time, and more predictable, again, with less complications. So, and I think, again, it's to do with a bit of more lateralized. My glenoid as well is slightly lateralized, not as much as Mark's, but lateralized. And together with the shape of the liner as well, we get very good rotational movement, which are the problem of the surgeon that says that hemi get better results than reverse when they get good results, because notoriously in reverse shoulder, you don't get good rotations. But if you use a lateralized glenoid like Mark's or a lateralized glenoid with a oblique liner like in my design, you get pretty good rotational movements, which are important for daily activities. So I think, in my opinion, reverse is the way forward.
Jean, you have to add, or you disagree with anything that the two have said?
I agree with both. In my
Okay.
hands, hemiarthroplasty, we cannot do it anymore for fractures. If you can reconstruct, you do an osteosynthesis, you do a fixation with a nail, with a plate, with graft bone. The most important to fix well the tuberosity. If you have the tuberosity in the good position, you can put after a total shoulder you can do a total shoulder prosthesis if the cuff is in the right place, if the tuberosity are healed. The problem of good results in hemi, it's a problem of short outcomes. We know that in the first 5 years we can have good results, but after 5 years we start to have lysis of the tuberosity and loss of range of motion. And for me, hemiarthroplasty for fracture don't exist anymore. I do osteosynthesis. If it's not possible to do an osteosynthesis, I will do reverse shoulder arthroplasty.
Okay, thank you, Jean. That's quite clear. So now, so have you all faced similar situations? These are multiple examples done by various people around, and most of you have come across these situations, I presume. And now I present to you this 45-year-old. It's a 4-part fracture, and he also has a brachial artery injury. So, Jean, what will you, or let me ask Offer first. Offer, what will you do for this one? 45. You just said you won't do hemi. I showed you a series of fixations, how they behave. So what's your choice?
Well, I will do at most to try and reduce it and fix it. I tend not to use the locking plates. I don't really like the locking plates. I think they're too rigid for this bone. I think that they have the best fixation between the screw and the plate, and therefore, if something going to give is the bone that's going to give, the soft bone is going to give. I use a minimal fixation with what I call the palm tree technique with 3 wires and suture fixation. And as John said before, the key is to get the tuberosities right. Again, if you get the tuberosity right, then later on, if it doesn't work, if you develop AVN, if for some reason develop arthritis and all that, you have all the options to do. You can use a resurfacing, you can use a stemless implant, you can use a stemless reverse implant, or whatever at the later stage. In this case as well, you have the artery.
Offer, if you allow me to interrupt you, I got it. You're going for osteosynthesis, but for the sake of, for the benefit of the audience, can you speak 30 seconds more on the fixation technique, the palm tree? The wires are going from where to where?
Yeah, well, what I do is I use the anterosuperior approach. Again, in this case, maybe because of the vascular injury, you'll have to do a double approach as well. But I do the anterosuperior approach. This gives me the option to get to the posterior aspect of the shoulder easier. I just find the tuberosities. I put a stitch, a stay stitch between the insertion of the rotator cuff to the greater tuberosity, to the lesser tuberosity as well, and I put a bone spike and lift the head to position. I use a bone graft substitute block. It's tricalcium phosphate to put it behind the head to stop it from collapsing back. And when I close the book, when I close the lesser tuberosity to the greater tuberosity with one stitch, when the head is lifted, I actually created a 2-part fracture. I've got the head and the tuberosities as one piece, and I've got the shaft as the second piece. At this stage, I do a second incision in the area of the insertion of the deltoid, a small stab incision, and using a drill, a 4.5 millimeter drill the lateral cortex of the humerus. And through there, I introduce 3 pre-bend wires and spread them into in space, in 3D, like a palm tree, into the head, gently, and bury them under the skin. While I do that, this keeps the stability and allow a bit of axial flexibility in the fracture. Obviously, I call it more as an augmented conservative treatment, because you have to keep the arm in a sling for at least 3 weeks, see if there's any callus there, probably for 6 weeks. And then at 6 weeks' time, I take the patient again to theater, take the wires out, and carry on with exercises. We have very good results with that. I can show a case if you want. I've got a case.
Just one line more. How many cases and how many years you've done this?
Well, my fellow actually is I think at the end of submitting now, over 20 years of experience with this technique, with very, very good results. Of course, there are some failures, but you know, once you have the tuberosity in the right place, and even if you get an AVN at the end, you can still do other things. We had a few patients that we had to convert them to arthroplasty later on.
Appreciate. Mark.
So for me, the challenge I would have with this case is assessing intraoperatively that I have an anatomical reduction. So clearly, you know, the things that need to be addressed here first, the vascular injury needs to be addressed. And so that probably, in my mind, would perhaps require some changing of the conjoint tendon. That's the first thing. The next thing is, how do I reconstruct the fracture? So I would do it through a deltopectoral approach so I can get to the artery. And then my next thing is try to make sure I can anatomically reduce the fracture. And I don't know that I'll be able to. So if I can't anatomically reduce it, this patient's going to get a reverse, because if I don't anatomically restore the fracture, even if I fix the fracture, the outcome is going to be poor. So that would be how I'd approach it. I wouldn't be so convinced that I can fix this anatomically and provide the patient a predictable outcome.
Appreciate your honesty about the fixation. Jean.
Yeah, I do a lot of trauma cases in my hospital. First of all, I will let the vascular surgeon to operate to be sure that the arm is viable. After that, I will do a nail with a graft bone, and I've got some cases that I can show you if you have the time. If we have the time after, and I will try to reduce. I'm not sure that it will be possible, but even if the head is not viable anymore, if we have it in the good position for two months, it's great. And I will do it by a superior approach to be sure that I can put the greater tuberosity in place.
Okay, which nail is that? Can you share with us?
I used Equalis nail.
Okay, thank you.
From right Tournier.
So this is what was done on this patient, and that is his result. This is 18 months post-op. And of course, the vascular surgeon put a graft for the artery there. So is it fair to say, chaps, that when it comes to displaced forepart, those nasty fractures, I think there is a need to innovate in our current available techniques of internal fixation. Is that a fair statement? Mark, do you think, I'm talking about that age group where reverse is not the first choice. It's a different thing when the patient is 65, 70 and above. But what if he's like this guy or 50?
Yeah, you know, I've spent so much time in the 90s and the early part of 2000s thinking about fractures that I'm done thinking about fractures. I'll leave it to you guys because I still treat fractures, but it's far less of my practice now. So it's not something I'm continually confronted with in terms of me feeling that I'm unable to come up with a good solution. So I wouldn't disagree with it, but for my personal observations in life at this point in my career, it's just not something that I could comment on because it's not that frequent of an issue that I have to confront.
We understand. So now, because we are running short of time, this is the last case, but I think I will perhaps skip this case and give an opportunity for Offer was offering us some cases to show. So if I now stop my cases at this point, thank you very much, all the panelists. And may I stop sharing my screen and Offer, are you ready with your cases?
Yeah. Which one you want? Do you want the one about the fracture fixation?
In India, we have many, many cases of fractures. So our main indication for arthroplasty is fractures. That's the top of the list. Failed fixation.
Well, I can show the palm tree technique if you want.
Yeah, whatever 2-3 cases you like, and maybe then if there is time, Jean can show us that nail that he's talking about.
Okay.
So maybe a couple of cases from your side. Is that okay with you, Mark?
Sure. I have our stop time is what?
It's about now, so we may have to extend it by 10, 12 minutes if that is okay with you.
Yeah, 10 minutes is great.
Okay.
Can you see my screen?
Yes, we can.
So I'm just actually, if you see this, I'm just quickly asking which type of fracture it is. And anyone wants to comment quickly?
It's a 3-part fracture, valgus impacted. Okay.
Well, if you look carefully, it's a head split fracture. There is a double line there.
Right.
That's the 3D CT scan of the fracture. What would you do? Would anyone treat it with nothing like the proffer suggested?
Hey, was Proffer, wasn't there an English study?
Yeah, which I think it's a very bad and poor study, which actually created havoc around the world.
I just wanted to confirm it was done in England. That's all.
It was done in England, unfortunately, but I'm the major opponent, and I actually fight every place against this study because it's the conclusions are so wrong. Anyway, I mean, I see so many patients that are suffering because of that. It's unbelievable. Yeah.
Sorry.
Anyway, anyone will do a locking plate in the panel? I know that Jean will do an iron nail and suture fixation, mini open reduction, suture percutans fixation or closed. Okay, so that's the technique.
Not mini open, open.
So that's the technique. I do an anterosuperior approach. I fix the tuberosities together and put the bone graft substitute, as you can see there, and that's how it looks 2 months after surgery. I take the wires out after 6 weeks. And again, that's the technique, that's the anterosuperior approach and the bone graft substitute, the 3 wires, as you can see here. This is a very, very expensive instrument kit. That's why, it's very, very expensive, cost nothing. Again, another patient with this, and this lady, she's 76 years old, and that's a year down the line, no wires, no metal work, nothing, and good function. Again, I don't know, nowadays, maybe I would have done a reverse straight away on this age group, but maybe it's overdoing, maybe you can do that. The advantage of the reverse, that the recovery is much, much quicker. Okay, so let me show you another case, which is, okay. So this is a 62 years old gentleman, very active. He's got a painful restricted shoulder. He's got a malunion after previous fracture sequela. What would you do? Nothing, resurfacing, hemi-arthroplasty, stemless anatomic, stemmed anatomic, or reverse shoulder. Mark.
I would have to examine him to really get a sense of how stiff he is, but I think you could certainly make an argument for doing a resurfacing with a total shoulder, or a stemless with a total shoulder, or a short stem anatomic total shoulder. You can also make an argument that if you were to attempt that and you found that his soft tissues were not very compliant, then you'd probably be more apt to want to do a reverse. So I would be prepared either way to do both. And interoperatively, I would make the decision about how the soft tissues moved. You know, with the malunion, you have the loss of motion because the muscle tendon units are no longer going into the correct pathway. In other words, they're not going how they're changed in terms of the orientation of the travel of the muscle. And the second problem is there might be scarring of the muscle tendon units. So even if you were to release them, and you find that they just don't seem to allow motion across the joint, in which case a reverse would allow me to modify some of those features.
Yeah. Well, he's got severe wasting, as you can see, and I think that these muscles are in pretty poor shape. What will you do, Jean?
I will call Professor Levy, because it's necessary to put a reverse. We can see the atrophy here of the infraspinatus and supraspinatus fossa. Also, we can see it in the Coutalier that we are in the atrophy of the supraspinatus. And I think the only solution, it will be a reverse. But even a reverse, it's a problem because we have a displacement in VARS of the head. And it will be difficult to achieve, once again, a good result to put the posterior cuff with the prosthesis with a shaft guide, axle guide. I think it's a very, very good indication for a stemless reverse.
Sanjay?
Yeah, if the patient has enough symptoms and is not happy with what his condition is, then a reverse shoulder arthroplasty.
But you have a problem here with the reverse because, again, as Jean said, you have the deformity of the shaft. Anyway.
So could I just comment? Because I reported on this series of malunions maybe 10 years ago. And what we found is if you get the socket centered within the axis of the tuberosities, then you can really end up with a very good outcome. So you can use a short stem or a mini stem or a very thin stem that allows you to put the socket inside where the tuberosities are, and then that will restore your balance.
Yeah, but the problem was that the cuff was as you said, the cuff was poor and very scarred. Anyway, that's a patient that, not my patient. That's what the surgeon decided to do. And any comments on that? That's what the surgeon decided to do. He did a hemi. You can see that he tried to repair some cuff with the anchor there, but the patient is still the same, very painful, very restricted. Any comments, Mark?
It's just overstuffed. I mean, you can see that the head is eroding into the glenoid, so it's not surprising the patient is symptomatic. So, I mean, in order for this surgical procedure to be successful intraoperatively, you need to make sure that the glenohumeral joint moves freely and it's not restricted. And that is a challenge to accomplish. So
what would you do now?
It's a little easier. I would do a reverse and I would release scar to get adequate mobility of the glenohumeral joint. And I have a variety of different glenospheres that I can use to optimize my length tension of the muscle tendon units about the shoulder. If the muscle tendon units are attached, I would see if I can leave them attached, but if they were too scarred and they would prohibit motion, then I would release them.
Sanjay?
Yeah, I think this to me is day one failure. I think it's an incorrect choice of surgery, and I appreciate that the stem is the shaft is deformed, but still my choice would be a reverse in this case.
John, you agree?
Big problem now, because now we cannot put any more a stemless reverse, because he stemmed
Well,
the diaphysis.
That's the guy where, as you were referred to me, that's his movement. And you can see that's what, what would you do now? Tell him that's it, sorry. Revise to a stemless anatomic shoulder, revise to another stemmed anatomic total shoulder, or revise to a reverse. And if reverse, which one? Because of the deformity.
Stemless, of course.
Yeah.
Stemless after stem, it's complicated.
Yeah. So this is what I did. This is actually about 6 years down the line. You can see this guy function, excellent function. He returned to all his activities, returned to his sporting activities. That is his sporting activity. He's jumping off airplanes with his squirrel suit. And when I first...
Ofer, is that stem, it looks on that x-ray, the stem's not in bone. Is that just
correctly. But there was no way I could get it because of the deformity inside to get the good tension of the tissues. And that's the best way I could do it. And that's 6 years down the line. There's no change, no problem whatsoever.
How did you secure the stem within the bone then? I mean, if it's not
That's,
in the bone.
that's the secret. That's the secret of the shape of my implant, because of these 3 fins fixation.
This sort of reminds me of the fracture case. I mean, I would hate to have to try to do this 10 times and hope for 10 outcomes like this.
Again, to be honest, that's not the way I wanted the X-rays to see, to look. But that's it. This is what it is. And this guy is over the moon. He can do his sports and he can jump off planes like that. When I first saw that, I said, "Oh my God, no, with my shoulder. What you're doing." And what they have to do, they have to open the arms like that to jump into the air. And imagine how much force going through the shoulder. And he said, "Prof, I'm going to do it whether you allow me or not. This is my life. I did it before, and I tell you, you improved my technique." I said, "How come?" He said, "Before I couldn't open my arm at all. I used to go down in spirals. Now I can fly." So I don't recommend it for the improvement of your flying techniques, but that's just the most
Ofer, the one comment I would say is, if you looked at that article in which I referred to, you'll see that in one of the cases, I cut the stem and I just cemented it proximally, and but the key is getting that socket. So if you looked at where the tuberosities are, that the distance from the tuberosity socket is close. And once you have that experience with malunions, you realize you should never use an onset humerus, because every time you use an onset humerus, you change the relationship to the socket and the tuberosities.
I agree.
Again,
I agree.
That principle is why you won so strong on that case, and great job.
No, I agree completely. I mean, I think that the inlay is by far much more accommodating than the onlay. The onlay will distract you much more. Yeah.
Okay, chaps. Now we are running short of time, but there are 2 burning questions to conclude the whole session. One is for Ofer and one is for Jean. Ofer, the question, by the way, we have 1,200 people watching. So what a tremendous contribution you guys have made. 1,200 people are watching as we talk. The question to Ofer is, which cases are you compelled to do a glenoid replacement if you are doing an anatomic total shoulder? And in which cases you feel okay to do a hemi for an arthritic shoulder? Cuff intact.
just a second. I'm actually, just a second. I need to.
Okay, while you find that, tell us when you're
Okay,
ready with
I'm
your
with you.
answer.
Yeah. So the question,
Okay.
the question was which one I will do a reverse and which one I will do an atomic.
No, sorry. The question is, when do you're doing an anatomic arthroplasty, number one, not a reverse.
Yeah.
Because you do many surface, when are you compelled to replace the glenoid?
To be honest, I will probably will not replace the glenoid in almost any case. I had about 10 cases out of 1,000 of more than 1,000 of cases of resurfacing that I had to go back and put a glenoid in because of pain in the shoulder. But these were really in the old days. If now I have this problem, I will actually revise them to a reverse, a stemless reverse. If I have any doubt about the glenoid nowadays, I will do a stemless reverse shoulder. I think that on the long run,
Which is that glenoid where you are not comfortable doing a hemi and coming out?
Well, I would say that some of the B2 glenoids, when you have a severe subluxation, posterior subluxation of the humerus, nowadays I will do a reverse. I will tend to do a reverse more than, although I had very good results with the resurfacing to balance the soft tissues and bear the ridge in the middle. I had pretty good results, but I'm tending more to err towards the reverse now because the results are much more predictable. And as I'm using a stemless reverse, I'm not losing anything for the future. So I'm quite easy with that. Yeah.
Okay, thank you. Jean, the question to you is, when you are doing stemless, how do you assess the bone quality in the metaphysis that you're not running a risk of loosening of the stemless?
Yeah, we have a scientific way to use T-scores for osteoporosis, or we have a practical thumb test. I do the thumb test.
Okay, thumb test. Okay, got it. Okay, so thank you so much, gentlemen. Really appreciate Mark offer, and Jean. Thank you very much. Really appreciate for your giving us the time. We had 100 people.
Yeah.
Thank you very much.
And everybody has enjoyed a lot of good feedbacks.
Thanks, guys. Goodbye.
Thank you very much.
Thank you to Ortho TV and especially to Evolutus for making this happen. Thank you, gentlemen. Thank you once again.
Bye.
Bye-bye.
And thank you all the audience. Thank you. Bye. Stay safe.